Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover calcium metabolism. So you have to keep calcium in mind for these exams because they usually ask a lot that we're going to cover in this video. Okay. So first of all, let's talk about some general rules. The total serum calcium is going to be divided into these components. The 40% is going to be bound to albumin. Bound to phosphate and citrate is going to be around 10%. And the free ionized calcium, which is the active component of the serum calcium, is going to be 50%. Now, remember this. Albumin has acidic amino acids, which are aspartate and glutamate, and they have these carboxyl groups, okay, which are these ones. And this is going to be important for some of the metabolic states that we're going to cover in this part of the video. So the first thing that you need to know is hypovolemia. This one specifically alters the total amount of calcium. So it alters the total amount of calcium. The free ionized calcium is going to stay the same, and the patient is not going to develop symptoms because the free ionized calcium is not going to be altered. Now, this is because for every gram per deciliter loss of albumin, your calcium level is going to drop 0.8 milligrams per deciliter. So every time you see a patient that has hypocalcemia, you need to correct first for the hypoalbuminemia if they have. Now, what you do is 4.0 is the normal state, the normal amount of albumin in a person that is healthy. You're going to calculate the difference between the normal albumin in a healthy person and the one you measured in your patient. Now you're going to multiply that one for 0.8, which is the one that you're going to lose for every gram of deciliter that you lost of albumin, and you're going to add that to the measured calcium that you have. And this is going to compensate for the hypoalbuminemia, and this is going to tell you the exact amount of calcium that the patient has. Now, the other metabolic state is going to be respiratory alkalosis. Remember, this is a state in which your respiratory rate is going to be increased. The patient is hyperventilating, so they are getting loss of CO2, okay? So they are getting loss of CO2 in their blood, and this is going to alkalinize the blood, okay? So as we talked about, these patients are going to have alkalosis, right? The alkalosis is going to unfold as a drop in hydrogen concentrations, and now these carboxyl groups we mentioned are going to transform into a negative state, which attracts calcium. And so your ionized calcium is going to drop because you're going to have more negatively charged carboxyl groups in the blood. Now, the free ionized calcium is going to be altered. This is going to drop the free ionized calcium. And so the patient is going to have symptoms. And so these symptoms are usually tetany, and we're going to talk about them more specifically in this video. But remember that the total amount of calcium is going to stay the same. So the calcium in your blood stays the same. It is just attaching to albumin due to this alteration in the carboxyl groups being now negatively charged. So keep this in mind for the questions of the exam, and always consider if you have a patient that has hypocalcemia, correct for the albumin, and check the pH to see if that's the reason behind them having tetany symptoms. Okay, now in this part of the video, we're going to talk about the specifics of the hormonal regulation of the calcium metabolism with PTH, vitamin D, and calcitonin. So first with PTH, it has some functions. The most important one is going to be that it increases the calcium reabsorption in the distal tubule. So this one, in addition to the lower phosphate reabsorption in the proximal tubule, is going to give us a net effect of increasing calcium and a decrease in phosphate. And the regulation of this is because if you increase both of them, the net effect is going to be that phosphate and calcium are going to add up together in the blood, and so your calcium levels are going to stay the same. So what you want to do is you want to increase the calcium absorption and decrease the phosphate reabsorption in the kidneys. Now, PTH also has indirect effects. The first one's going to be that it increases the intestinal reabsorption of calcium and phosphate. So it increases both calcium and phosphate indirectly due to the upregulation of this hormone, which is 1-alpha hydroxylase in the proximal tubule. And this one is the last step in the activation of vitamin D. So vitamin D is actually the one increasing the reabsorption of calcium and phosphate, but it is due to a regulation of PTH in the kidneys, okay? Now, it also increases the number and activity of osteoclasts, increases the activity of osteoclasts, and this one is going to lead to increased bone reabsorption, and this one too increases calcium and phosphate. But this effect, the lower reabsorption in the proximal tubule, is going to be mandatory for this hormone to increase calcium. Now, the regulators of PTH is going to be the contrary, hypocalcemia and hyperphosphatemia. They both cause increased secretion of PTH. Now, with vitamin D, we have its metabolism. There's two ways in which you can get vitamin D. The first one's going to be the diet, cholecalciferol from fish, ergocalciferol from plants, and also the skin. There's photoconversion of cholesterol to cholecalciferol, okay? Now, in the liver, you're going to have two steps for its activation. The first one's going to be in the liver with hydroxylation and forming this one, calcidiol, which is hydroxylation in the 25 portion of the vitamin D. And after that one, you have your indirect PTH effect, which is in the proximal tubule, you increase the 1-alpha hydroxylase and you generate calcitriol, which is the 125 hydroxylation of the vitamin D. And now this one's going to be your active form and is the one that's going to generate dysfunctions. So in order for you to have a vitamin D effect, you need PTH. Now, functions. Increased calcium reabsorption in duodenum and the distal tubules, so in both the intestines and the kidney. Increased phosphate reabsorption in intestines, jejunum and ileum, and the proximal tubule, both intestines and kidney. Remember, this one is contrary to the PTH effect. And increases the stem cells to convert to osteoclasts, but it is not in order for them to increase bone reabsorption. In fact, the net effect is going to be bone mineralization. So that is the reason behind the vitamin D being important for your bones in the long term. So the net effect of vitamin D is going to be increased calcium by reabsorption and increased phosphate, okay? Also by reabsorption. Now, the last one is going to be calcitonin, and this one is, its function is not really well elucidated because this one comes from the parafollicular C cells, which are located, as you remember, on the thyroid. And these are the ones generating the medullary cancer of the thyroid. But if you take the parafollicular C cells, there's no acute changes in or long-term changes in the concentrations of calcium overall. So they really think their effect is rudimentary. It is an evolution preserved cells that only cause cancer. But the net effect of calcitonin is that it decreases the bone reabsorption. It is going to decrease the amount of calcium in serum. So we use it as a medication when the patients have certain conditions such as hypercalcemia. So that's the real use of calcitonin nowadays. So this is going to be it for the hormones. Next is going to be hypocalcemia and hypercalcemia. Now let's address hypercalcemia. And so let's begin with the etiologies. The number one cause is always going to be primary hyperparathyroidism. And this one is going to be further discussed in another video. So we're going to go to the specifics of that one. Now, another reason may be malignancy, and this can be either due to PTH-related peptide or due to metastasis to the bone with increased bone reabsorption. Okay, so this protein mimics the functions of the PTH, and this one is due to increased reabsorption. Okay, now granulomatous diseases, sarcoidosis, tuberculosis, histoplasmosis, and coccidioidomycosis, these are usually due to an increase in 1-alpha hydroxylase. If you have increased this enzyme, now what you're going to have is increased vitamin D activation, and that's going to lead to hypercalcemia. Now, also patients that have vitamin D intoxication can generate hypercalcemia. The use of thiazide diuretics, remember thiazides keep the calcium while loop diuretics get rid of the calcium. So patients using thiazides can generate hypercalcemia. There's also alteration in the kidney with lithium, so this one also may be a cause. For jet disease, remember these patients have a duality between bone formation and bone resorption. Okay, so during the bone resorption state, they may generate hypercalcemia. Also, patients that have prolonged immobilization, this is usually a patient that has some other chronic condition. They immobilize the patient, they get bedridden, and now after a few days in the ICU, they develop hypercalcemia. Okay, so keep this in mind for the exam. Now, for the signs and symptoms, it is this mnemonic: the stones, bones, groans, psychiatric overtones, right? And so let's keep them focused. So for the stones, remember that in the kidneys, it may increase your risk for nephrolithiasis. Okay. For the bones, these patients usually develop joints and bones pains. For the groans, you have decreased bowel activity because of the effects of calcium on the intestinal neurons, generating constipation, nausea, vomiting, and also because these patients may develop pancreatitis, precipitation of calcium, and they can also generate ulcer disease for unknown mechanisms. Now, the patients also have increased production of urine due to alterations of the kidney from the increased calcium. Remember, calcium is an important regulator of the concentration of the urine. And also the psychiatric overtones, right? These patients can generate decreased mental activity, lethargy, and confusion due to alterations of the functions of neurons. Now, it is described that these patients may also generate hypertension, and you may see on the electrocardiogram short QT due to increased rates of repolarizations due to increased calcium. Okay. Now, for the treatment, what you need to know, there's guides referring to severe hypercalcemia, mild and medium and whatever. But for the exams, keep this straight. If the patient has severe life-threatening hypercalcemia, meaning these patients have symptoms, okay, or they have a calcium higher than 40 milligrams per deciliter, what you need to do is hydrate the patient. These patients usually dehydrate because of the increased formation of urine. And also, this is going to generate nephrolithiasis. So hydrate these patients, avoid dehydration, and that's when you decide if you need to add calcitonin. If you have it available, it is a great drug. It lowers rapidly the calcium concentrations in serum. And if your patient is not dehydrated, okay, this is important. If he is not dehydrated, then you add loop diuretics, because otherwise the loops are not going to be able to promote this mechanism of calcium, of getting rid of calcium. Now, for the long term, that's when you consider the bisphosphonates. Never add bisphosphonates for acute management. And because hypercalcemia has many differential diagnoses, always, if you have a patient that has no severe life-threatening symptoms, consider getting to a diagnosis, because this is the specific part to get for a proper treatment. So differentiate between severe life-threatening, hydrate these patients. If they are not in this condition, then consider chronic management for hypercalcemia. Okay, so now let's finish with hypocalcemia. So for the etiologies, remember the most common cause is going to be hypoparathyroidism, and this one is usually due to removal of the gland. The patients that have a thyroid cancer and then they remove thyroid along with the parathyroids, and now these patients have hypocalcemia. You need to replenish PTH. Also, renal failure. This one has two mechanisms. The first one being it lowers the amount of active vitamin D because it is going to lower the amount of 1-alpha hydroxylase, and also because it is going to increase the amount of phosphate available in blood, and that is going to attach to calcium and it's going to lower the calcium serum levels, right? Hyperphosphatemia, same mechanism. Hypomagnesemia, remember magnesium is a permissive electrolyte for the PTH to be secreted, and patients that have malnutrition, alcoholism, and diabetes may have this one. We're going to talk further for this condition in the diagnosis and treatment part of this video. And also loop diuretics, remember loop diuretics lose calcium, so being in a chronic state of loop diuretics may generate hypocalcemia. Phenytoin, alendronate, of course the bisphosphonates, foscarnet, they can all cause hypocalcemia. Alkalosis, remember that increased pH is gonna get rid of hydrogens, and so the carboxyl groups of the albumin are gonna detach the hydrogen and are gonna become available for calcium to attach them. So that's going to lower your calcium levels. That's going to generate hypocalcemia. And remember, this is a symptomatic hypocalcemia. Okay. Now, pancreatitis, keep this straight. Hypercalcemia may generate pancreatitis. Pancreatitis may generate hypocalcemia due to calcium, due to calcification of the tissues. Now, massive blood transfusion. These ones are due to increased citrate in these transfusions. Remember, phosphate and citrate are the components that attach to calcium in blood. So if you have increased citrate, then you're going to generate hypocalcemia. Now, for the signs and symptoms, remember that calcium is an important membrane potential stabilizer. And without calcium, the threshold potential is going to be lowered. So there's going to be increased hyperexcitability of neurons, and that is going to generate a state named tetany. Now, there's going to be signs specific like carpal spasm. This is one, the one commonly known as Trousseau sign, which is with an arm manometer and the patient generating the carpal spasm as after you are measuring the blood pressure, and also facial twitching, known as Chvostek sign. You perform percussion of the mandible and the patient is going to generate facial twitching. Now, circumoral numbness is going to be commonly referred by the patients. Patients can also develop seizures. And remember that hypercalcemia generates shortening of the QT. Hypocalcemia, the other way around, generates prolongation because there's not available calcium for repolarization of the membranes. And now, formation of cataracts, this one is described. Mechanism is not fully elucidated. Now, the diagnosis and treatment. The first thing that you need to do is first check if this is a true hypocalcemia. And what you need to do is, if you identify one, repeat the measurement, and now you perform a correction with the formula that we mentioned earlier, which is the difference between the normal amount of albumin, the one you measured, multiplied by 0.8, and then added to the serum calcium. And that's the way you check if this is a true or this is just an hypovolemia. Now, you need to check then the magnesium. Remember, this one is a permissive electrolyte for PTH. If it is low, then you should replenish magnesium because otherwise you're not going to be able to reestablish the calcium levels in these patients. Now, if the patient had a recent blood transfusion, this may be behind the mechanism we described with the citrate. Check for those, and then if the patient is symptomatic, give calcium, preferably in IV presentation, and then that's going to be for the video.